So current management options, well, erectile dysfunction, for whatever the reason is that you have developed it, and I know tonight predominantly it's because of prostate cancer management, but lifestyle change. I see people sometimes who say, do you know what, I've got a better sex life now than I had before I got diagnosed, because it may have been over the years they've been increasing the hours they've been working. They work crazy hours, they come home at night expecting to have good sex, tired, can't get an erection because they're actually tired, so their arousal response isn't as good. Their partner may be too tired, but they're in a relationship and they should be having sex, so we better do it. So they have failed sexual encounters. So just looking at your lifestyle, when are you trying to be sexually intimate? Is it, at a reasonable time? Are you relaxed so you can get aroused? Psychosexual therapy, well, I did the training a few years ago because, as I mentioned, me just talking about treatment options for ED ticks a box, but it doesn't always manage people holistically. And psychosexual therapy is important because we all have life events that happen to us along the way that impact on our sexual function. And I remember seeing a couple in the clinic a few years ago at Wickham. And the lady came with her husband and she cried through most of the consultation, and actually talking to her through the tears with her husband sat there, felt very guilty at the end of the time in the clinic. And I said, why should you feel guilty? How you feel is as important as your husband. And she'd been involved in a car accident and there'd been some trauma, so sex had been difficult for them anyway prior to a diagnosis. So there are factors that impact on our sex life, aren't there? It doesn't have to be just a disease that's been found. I always shocked the plastic burns consultant a few years ago when I set fire to myself cooking, and I lost the skin on my arm and hands. And when I said to the plastic burns consultant I'd lost my desire for sex, you can imagine he dropped the forceps like beyond belief. Oh my gosh. But we're all human and things can happen, so just be aware of that. It's not just about prostate. Oral pharmacotherapy. I do oral pharmacotherapy, not just oral therapy, because do you remember Hugh Grant and the prostitute who he was asking the phone numbers for? So I always put oral pharmacotherapy. We've got 3 tablets, and I'll talk a bit more about them in a moment. Intraurethral and intracavernosal therapy. One is a pellet, again, I'll mention, and one is an injection. Vacuum devices, which we've heard of just now. Implants or combining therapies. You may be looking at combining several of these factors, and I certainly think that's the way forward. Schedule 2. Tan mentioned about getting a vacuum device on the NHS, and that's all because of Schedule 2. In '98, when Viagra came out, the government said we can treat certain people with erectile dysfunction on the NHS, and we will allow them 1 treatment a week. And that does include a vacuum device, but you have to have an illness on the list. So we do have prostate cancer on this list. Now, I do know this changes dramatically around the country, and I think it's just changed in Oxfordshire. I was hearing that it's 2 treatments a month. Has anyone found resistance from their primary caregivers and getting treatments prescribed? No, well, that's good. Yeah. So I think it's important you are aware of these guidelines, because that helps you to manage, hopefully, getting things prescribed. When you have a prescription written, it should have SLS on the list, that you're on the selected list scheme. And that means you've got an illness on the list, and that allows you to get it as an NHS prescription. So the PD5 inhibitors, that's the class of drug they belong to. Sildenafil citrate, you can get that in 25, 50 and 100 milligrams. Tadalafil, Cialis, 10, 20 and a 5 milligram and a 2.5 milligram. Vardenafil, which is Levitra, 5 milligram, 10 milligram, 20, and also an oral dispersible tablet in 10 milligram that dissolves. You need sexual stimulation for these tablets to work. They won't work without. So all the jokes about just popping the tablet and up it comes, that's not true. You do need sexual stimulation. You shouldn't use them if you're using nitrates. And the reason being that if you take these tablets, they dilate your blood vessels, they drop your blood pressure slightly. Most people think if you take the tablets, they raise your blood pressure because your face goes red. And a lot of people worry that they're going to have a heart attack and all the fear that's been in the tabloids. They're actually excellent drugs that dilate vessels. You need the sexual stimulation as you would normally. If they work, you can get an erection, you can orgasm. If you can still ejaculate, because it's not because you've had radical prostatectomy, you can still ejaculate and then you will go soft. So it's very much like the normal response. Choice is very important, and again, Tan mentioned it earlier on. What you want to choose is your choice. You only the people who know what goes on in your sex life. And I always say to patients, we've got 3 excellent drugs. We've got 1 long-acting drug and 2 short-acting. And what I mean by that is the short-acting medications, Viagra and Levitra, are in your bloodstream for about 4 to 6 hours, the ability to get the erection. So it's the ability when you have sexual stimulation. And that might be self-pleasuring if you're not in a relationship. But the long-acting Cialis is in your bloodstream 24 to 36 hours. So the ability to get the erection is a longer time frame. And things have changed slightly, that we have got a low-dose Cialis tablet of 5 or 2.5 milligrams, which people can take daily. And how that works is by the 5th day of taking the low-dose Cialis regularly, you get to a steady level in your bloodstream and then it normalises you for sex. And you don't have to think about when to take the tablet. Whereas taking it what we call on-demand is, well, I may have sex once a week and I'll choose to take that tablet once a week. So they're the differences. And the side effect profiles are different. That facial flushing, a stuffy nose, a headache or indigestion may be side effects. You may get them with 1 tablet but not the other. So unless you've tried all 3 independently at the maximum dose, I wouldn't consider it a failure. So remember that, because I often think it's a bit like Coca-Cola. Everyone knows of Coca-Cola, but they may not realise there's Pepsi and other makes. So try them independently. Muse, medicated urethral system for erections, and that's a little pellet that you insert down the end of the urethra. That's the applicator, and you keep it in the fridge, but it works better at room temperature. Go to the loo and pee. Either you can or your partner can insert it down the end of your penis. It's really wet with urine and it slips down very easily. And you pop it down, push the button at the top, and the little waxy pellet about the size of a grain of rice stays in your penis. You take the applicator out and then you massage the penis, and it helps the waxy pellet dissolve, and it spreads within the tissue of your penis, and it relaxes smooth muscles. It helps you get an erection. So men who've had a radical prostatectomy, your nerve supply is altered, as we've heard mentioned. But what you can find is that the tablets may not work on men who've had a nerve injury with the surgery, initially anyway. But you can bypass that by going to use a drug that works just on the penile tissue and just relaxes it. So if it works, it can work very well. And it just works on a different way to the tablets. So don't give up hope. If tablets don't work, move on. Think of it in a stepwise approach. And then injection therapy. Well, I think it's fantastic. And if things don't work, I early on inject, because what I don't want to happen is men to get negative, for you to get despondent, not having erections anymore. Most people say, you know, they'll run a mile. They don't want to try injections. But it's a very small needle. It's very similar to a diabetic insulin needle. And people describe it as pricking their finger with a rose thorn. And I teach people to think about the penis as a clock. And at 12 o'clock, you've got the midline. And at 6 o'clock, the urethra that you pee through. These 2 cylinders here, your corpus cavernosum, that's what fills with blood naturally when you get an erection. So if you imagine you get your erection, it fills it with blood, it's a bit like a football. Once it's to capacity, it's hard and erect. The Muse pellet would have gone in there, and it has to absorb through into here. for it to work. But the injection therapy, you inject directly into the corpus cavernosa. So on one occasion for one erection, you inject on one side. The next time, 24 hours later, no more than 3 times in a week, you would inject on the opposite side. Because if you keep injecting into the same side, the tissue can thicken where you keep pushing the needle in. So you could get a curvature, and you want to keep the penis straight. But injection therapy works very well in about 90% of men. So although it sounds daunting, partners can inject in foreplay. It's a great drug. What happens with injections and muse is you keep your erection until the drug wears off. So when I spoke about tablets and you having an orgasm and ejaculating and going soft, you won't if you use muse or injections, because the erection stays there until the drug fades. Vacuums, well, I won't mention any more because we've had a good session on that about why they're important. And implants, you can get bendy rods, malleable rods, and you can get inflatables. And this is a last resort. I would say post-radical prostatectomy in particular, 3 to 5 years can be the recovery of erectile function. And at 5 years, if you are not happy with what you've got, or 3 years and you're not happy with where you're at, with whatever treatment you may be using or not, certainly we should be discussing implants with patients. And I don't think we do it enough really in the UK. But what happens is that tissue that I spoke about, the corpus cavernosum, if it's not working, you're not getting an erection, the surgeon will scoop that tissue out and either insert 2 of these malleables. So your penis will bend. I used to have a Mickey Mouse when I was little, like you bent the arms up and down. And that's what would happen to the penile tissue, because they're erect. So you've either got the penis down in your trousers or out and up to have sex play. And with the inflatable, the pump sits in the scrotum. There's a reservoir in the abdomen, and the cylinders are inserted into that corpus cavernosum. And to get the erection, you squeeze on the pump, it brings fluid from the reservoir, and it inflates the cylinders. And then to go soft, you just reverse the process. So that's, I had a man say, I don't want my grandchild sat on my lap feeling my rods, quite rightly. So he chose to go down the inflatable route, so you can come up and down whenever you want it.